For those of you who do not know me, I'm Jennifer Kelley. I think most of you know me. Hi, Kenneth. I actually trained here in med-peds and then stayed on as faculty and now an assistant professor of internal medicine and pediatrics. And also about 6 months ago, I became the medicine clinic director, which has been an interesting job and what prompted my interest in this topic for Grand Rounds initially, as well as the fact that over the past 4 years, this X+Y residency schedule has been proposed in our own residency. So I thought it would be a good topic to discuss and look at what research we have and what evidence is out there regarding these new residency schedules, specifically the X+Y, which we're going to learn all about. So our objectives for today, first of all, we're going to talk about why we want our residents to be happy with their schedules in general and their continuity clinics in particular. We're going to talk about why we're even talking about changing schedules. What are the problems that plague our traditional internal medicine training schedules, which our residents, I'm sure, could give us tons of stories, including I have one we'll share. But we're also going to talk about new scheduling options and how they're being implemented in other training programs, and then review the evidence in support of these and talk about their limitations and the problems that you face with these different schedules. Disclosures, I have none. This is not really talking about particular medicines, but just, or medications, but about schedules. I do have a little disclaimer though. I did come at this with a bias, and I knew I was biased. I absolutely did love my continuity clinic as a resident. I still love my continuity clinic now. And so I will tell you that I started off probably a little biased to start with. I'm also usually averse to change in general, so that's my own little background so that you know where I'm coming from. So I wanted to start with something that we all know and we hear continuously. We know there's a shortage of high quality primary care physicians in the U.S. There are lots of reasons for this, and I'm not going to say that our continuity clinics and their setups with our inpatient versus outpatient is the cause of this. But I did want to review that we, for the most part, are having a shortage, and people that are wanting to go into general internal medicine are declining. These rates are declining, so we're getting fewer and fewer primary care providers out there. Internal medicine is huge when it comes to training. We train 25% of all the residents, which is great, except for the fact that our residents are less and less likely to actually go into the field of general internal medicine. So they're more likely to choose specialties. 1998, 54% wanted to go into general internal medicine, as opposed to 2003, 27%. We don't have any recent numbers more current than 2003. And then in addition to that, so our internal medicine residents aren't wanting to go into general internal medicine. Our U.S. medical grads aren't wanting to go into general medicine either. Their rates have decreased from 15.7% of 1998 U.S. medical grads to 6.7%. We're planning on going into general internal medicine. So this is an issue. So what I wanted to talk about next is, does resident satisfaction with their continuity clinic and their outpatient experience correlate with their career choice? So yeah, there are a lot of things that go into play with why you want to go into a particular field, including lifestyle, including you're absolutely passionate about cardiology, just a lot of factors. But does continuity clinic and your outpatient exposure play into that at all? So they did a survey at 3 different medical school, or 3 different residency programs, Mount Sinai, Temple, and Johns Hopkins, between May and June of 2011. They surveyed 225 residents and got a 90% response rate, so pretty good numbers. And they talked to them before their continuity clinic experience and then after their continuity clinic experience. And what they were asking was, what is your likelihood of entering the field of general internal medicine because of certain things that were happening in clinic? So I don't want y'all to look at all of this, but I wanted to show you what was significant. So if a resident felt like they had good mentorship from faculty in the outpatient experience, they were more likely to go into the field of general internal medicine because of that. They claimed that that mentorship influenced their decision to go into general internal medicine. And then other things I wanted to point out, again, that were significant, the time issue. So if a resident felt that they had a sufficient amount of time to see their patients in their outpatient experience, they felt like that played into their decision to pursue general internal medicine based on their continuity clinic exposure. And then last thing that I want to point out, this is an obvious thing to me, if the resident enjoyed their experience, if they had reward from their work, if they felt like they had their patient panel and those were their patients and they loved taking care of their patients and they had continuity with them, they were more likely to say that yes, that makes me want to go into the field of general internal medicine. I love this. So all that's pretty intuitive. The overall results were kind of what we would expect. So overall, the residents said they were pretty well satisfied with their clinic experience and their outpatient exposure. But 28% of responders said they were less likely to enter the field of general internal medicine because of their clinic experience, as opposed to only 11% that said, yeah, this was so great, I want to do this the rest of my life. So we're turning more people off than we are on. So I just wanted to do a little survey. So if you had to choose, and I would love for all of you to raise your hand when I ask you and be honest, you're not going to make me cry or hurt my feelings, but if you were given the choice of do you enjoy your general internal medicine wards versus your ICU rotation versus your clinic, which one would you prefer? Which one do you feel do you enjoy the most? So who says I enjoy ICU the most? All our future critical cares. Okay, and then who enjoys their inpatient wards the most? Yeah, a lot of y'all. What about your clinic? I think you two are lying. I know y'all are lying, but I love you guys and thank you. Dr. Moorhead, Dr. Klon, yes, I believe you. So, and this is what they found. So somebody actually did this study too. 2006, they surveyed 218 residents from Christiana, Johns Hopkins, and Henry Ford Hospital. And Henry Ford's in Detroit and more like, when we were comparing LSU to Johns Hopkins, it's obviously not the same, but Henry Ford and LSU is probably similar in our demographics and our residents and everything. But anyway, they surveyed 218 residents in 2006 from these hospitals, and they showed that residents do not value clinic as much as they value wards and ICU. So just like you guys here, this is an issue everywhere. So what different resident factors and clinic factors made them not value their clinic, made them think less of their clinic? The clinic variables were the preceptors. If they felt like they had great preceptors, they valued it more. If they had a good variation patient diversity, they had smooth patient flow in their clinic, they had adequate nursing support, well-stocked exam rooms, and didn't have many clinic scheduling issues, they tended to value their clinic experience more. That all makes perfect sense. Getting that to happen in practice is a little bit harder than putting it on paper. Resident variables. So these are our KANs and ISOMIs here. Those who valued morning report and those who valued inpatient wards also valued clinics. So the people that love things, and they love everything, and they're happy all the time. And yes, let me see another patient, I want to learn. And these are our residents, I think these are our residents that are just happy people in general. So another no-brainer, people who were planning on going into the field of general internal medicine also valued their clinic more. So the Dr. Moorheads and I of the world who love outpatient medicine love their continuity clinic. And then those who felt confident in their skill, obviously if you feel like you're doing a good job in taking care of patients, you're going to enjoy that more as opposed to if you feel like you're incompetent. So historically speaking, historically our internal medicine training has placed an emphasis on inpatient and subspecialty rotations. And many people would argue, well, that's where you kill people. So if you can't take care of a DKA, if you can't take care of acute respiratory failure, people die. If you can't take care of a skin rash, they probably aren't going to die. So that has been the argument historically. So That being said, the ambulatory medicine part of internal medicine has kind of been put on the back burner, and we use our continuity clinics historically to teach ambulatory medicine. These continuity clinics, just like here, usually have occurred during our core rotations, and core in quotes means our inpatient rotations. And many people think that this is a disjointed outpatient exposure. So that's an opinion. So what do clinics look like? We know what ours looks like here. I'm giving y'all a lot of background information. I promise we'll get into X plus Y in a little bit. But what do our clinics look like across the country? They did a survey in 2007 of clinic directors. This was my favorite study of all, and I'll tell y'all why. So they got a pretty good response. Most of the patients that we see in our residency training outpatient programs are lower socioeconomic status, so similar to ours. Take care of a lot of minorities. We take care of a lot of diabetes, hypertension, cardiovascular disease, depression. Again, this is no big surprise. This is what I loved. They did a study. I could have told them this. Clinic directors reported that they and their residents have significant stress about their clinics. So good to know. I'm glad somebody proved that. 80% of residents felt an overlap between their inpatient and outpatient duties. So this is not something that's unique to our program or unique to any program. It's universal. And then the other interesting thing is, even though they felt like there was an overlap, the majority of residents, clinic directors, and program directors still continue to prefer the weekly continuity schedule. And we'll delve into why that is a little bit later. But even though they felt like there was overlap, they felt like this, for the most part, was the better way to train our outpatient medicine. So this is shows the opinions from program directors and residents regarding the problems that resulted from your typical continuity clinic during your inpatient rotation. And so these are the problems that they thought that we faced. Competing inpatient and outpatient responsibilities. As you can see, most people thought it was either a little or a lot. Fragmentation of inpatient care. Not quite as much, but not quite as much, but still more skewed to a little and a lot. And then interruption delays in providing outpatient care because of inpatient responsibilities. So this is a problem everybody's seeing. I know every single resident has a story similar to these, if not many of them, but I wanted to say, just kind of tell y'all a story from my continuity clinic to bring the point home that there might be some conflicts, and it may affect our patient care, and it definitely affects our resident satisfaction. So I had a great continuity clinic. I had lots of patients that I really connected with, and I got a lot of reward out of seeing my continuity patients. I had one little lady in her 60s who was pretty severe COPD, and I had followed her for probably 2 years. This was my third year of residency, and I had followed her for probably 2 years and taken care of her pretty well, and we had her under pretty good control. She came in and she sounded terrible, and she looked terrible, and she said, I don't feel good. Okay, well, have you been taking your inhalers? What's going on? You've been doing so well. Why are you doing badly? And she said, I'm not gonna lie to you, I quit taking my medicine. And she started crying. And I was like, well, what's going on? What happened? You've always taken your medicine. And she said, my grandson just died. He had leukemia, and he just died, and I just don't want to take my medicine anymore. I'm just tired and I'm sad. And of course she's crying, and she was going into the whole story, and he had been in the hospital for a long time, and it was a terrible story. I was almost crying. My pager is going off nonstop. So it literally rang 4 times when I was in the room, to the point where the patient, in her tears, talking about her dead grandson, says, do you need to go answer that page? I guess I do. I mean, they paged 4 times. I'm sorry that this is an interruption, and maybe I should have turned my pager off. That would have been more appropriate. But anyway, I go to answer the page after we talk a little while, and it's a nurse, and I'm of course the resident on the team, and I said, well, why didn't you didn't want to call my interns? Yeah, I can take care of it, but why did you call me and not my interns? Oh, I didn't know who had this patient, so I knew you were taking care of it. I figured I'd call you. Okay, great. Thank you so much. Call my intern. So this is just something we face every day. And again, is this just part of residency? And we just have to say, residency is never going to be perfect, and it's not going to be, oh, yay, it's 4:30 in the morning, I'm going to get up and go see my patients. I mean, it's not the way it is, but is this something we need to continue to deal with and be complacent and just accept? So I think that's a very good question. So what is our current state of affairs? ACP states that the resident in the longitudinal weekly clinic may view the outpatient time as a distraction from what is considered a higher inpatient priority. Again, inpatient people die, and so it tends to get our attention and have our focus. The APGIM calls our clinic situation dysfunctional. ACP says it's inadequate, and there were many quotes of saying the residents were frustrated. The favorite title of all of these when I was doing my research was Residency Continuity is the biggest oxymoron of medical education, and I think it might be, but anyway, this is what everybody's saying about our current state of affairs. So who thinks there's a problem? So the Alliance for Academic Internal Medicine says there's a problem, APDIM says problems, Institute for Healthcare Improvement, Society of General Internal Medicine, ACP, ABIM, and they all are calling for improvement in patient-centered longitudinal care. Easy to say. How do we do it? So to start with, I just wanted to review our ACGME requirements because I do think that's a good start. So in 2000, these are as of 2009, so they called for 1/3 of our training must occur in the ambulatory setting, which we currently are good. We got all our bases covered. A clinical experience in outpatient chronic disease management, preventative health, patient counseling, and common acute ambulatory problems. They want us to have a longitudinal continuity experience in which residents develop a continuous long-term therapeutic relationship with a panel of general internal medicine, general internal medicine patients. We're working on that continuity. It should not be interrupted by more than a month, and it must include a minimum of 130 distinct half-day outpatient sessions. So unlike other programs like Pediatrics where they give you have to see this many patients during your PGY 1, 2, and 3 year, we just have to have so many sessions. So that is nice and it gives us a little freedom. So they are calling for programs to develop models that try to minimize the conflict between inpatient and outpatient responsibilities. Due to all of this change in everybody's opinion and now thinking that our traditional continuity clinics are dysfunctional and we need to do something differently, the Alliance for Academic Internal Medicine came up with a task force in 2007, and they recommended these things. They wanted our ambulatory education to improve. They wanted it patient-centered. They wanted it attractive. We're very much wanting to make our residents less stressed out. We wanted to eliminate or reduce the current conflict between inpatient and outpatient responsibilities. They called, this is not the ACGME, this is this task force, just to clarify. They called for ambulatory block rotations that should be developed to avoid the conflict between these inpatient and outpatient responsibilities. And that these rotations should have structured curricula and give you a longitudinal care of ambulatory patients. And they wanted different types of ambulatory settings. And they wanted a team-based system. So they're calling for a lot of different things. And these are the hospitals that were involved in the residency programs that were involved. There were 12 that were included in this task force that said, hey, figure out a solution to our curriculum. I'm sorry it's a little bit fuzzy, but there's some bigger programs like Mayo Clinic Rochester with 144 residents, and the smallest was this pointer, University of Cincinnati with 21 residents, if I said patients, I'm sorry, residents. So kind of a wide range of different programs that were involved in this task force. So to take one step back, they didn't really ask my opinion, but if they had, what would your ideal continuity clinic patient or continuity clinic be in your ambulatory experience be? And I do think continuity is the important thing. So we want continuity with a diverse patient population. We want ample time to learn from excellent attending providers. We want our residents to not be super stressed out about getting 5 pages while their patient's talking about their dead grandson. And I would like to not have nightmares about spreadsheets, but that's okay. But they did not ask my opinion. That is not the most scientific thing. It's an N of 1. So what did they do? They did do a cohort study that assessed the opinions of internal medicine residents and program directors. This was great because this was tied to our in-training exam in the year 2007, so I just missed it. But those of you that were training then took the survey, and they had almost 20,000 residents who completed this survey, so pretty good response rate. They also tied this to the program director's 2007 survey and had 64% of the program directors respond, so pretty good turnout. So what did the residents and program directors think was important for providing a good outpatient experience? So this is all what we would expect. Continuity clinic experience is considered high priority. That was important. Cross coverage of outpatients while in inpatient care was a little bit less, or inpatient service was a little less important, but still 48 and 51% said that it was somewhat important. You wanted a variety of outpatient settings. That was pretty clear. And increased subspecialty clinics. The residents favored that a little more than the attendings there. The no conflict with inpatient responsibilities. 69% of residents thought that was somewhat important, and 74% of program directors. And then, of course, having ample time with your outpatients. So, again, that seems to be a recurring trend. We don't want to feel rushed. We want to feel like we can take really good care of our patients and have the time to talk to them. So that's what the survey from 2007 said, that this would be an ideal clinic. Now, don't get too bogged down, I'm sorry, with these numbers. I'll go through what I think is important. They then asked, okay, how much time do you want to spend in clinic? So in 2009, they changed it to a third, right? ACGME said a third needs to be outpatient. So this predates that, and they were saying how much time is the perfect amount of time for your outpatient education. So as you probably could guess, our residents, which we've already established that y'all are not huge fans of clinic, our residents actually said we're going to divide this down 1/3 because that's what our requirements are now. The majority of residents wanted less than a third continuity, or less than a third outpatient exposure, as opposed to our program directors who wanted more than a third. Males tended to want less clinic than females, and that's been shown in other studies too. Probably has something to do with females are more likely to go into general internal medicine and less likely to specialize. And then, don't cheat and look, but what subspecialty plan made you least likely or less likely to want to spend more time in clinic? So what subspecialist wanted to spend the least amount of time in clinic? Y'all will be shocked. Cardiologists. They wanted the least amount of outpatient exposure. So over 70% of them wanted less than a third. Hospitalist wasn't far behind that either, so which that makes perfect sense to me. Why do they want to waste their time looking at rashes? So, okay. So what did they say would be the ideal clinic setup? And again, this is kind of right around when this task force was being initiated, and they were starting to really get very excited about we need to change how we're doing things. This is right around that time. So what did the residents say would be the best way to do clinic, to learn outpatient medicine? And so the most popular answer for the residents, 32% of them said they wanted frequent block rotations. And they wanted that in between their inpatient rotations, and they wanted to not be interrupted. So they wanted separate things. They didn't want ambulatory sessions when they were on inpatient service. As opposed to our program directors, who said they wanted, or the most popular answer, as you can see there's a wide range, but the most popular answer for our program directors with 36.4% said they wanted weekly half-day ambulatory sessions plus the occasional block rotation. So some of you in the crowd will remember we used to do this. I guess my 2010 was the last year we did this, 2011. We had something called PCC for the residents. So you had only a half day of continuity, no matter what. Even if you were on cardiology elective or allergy immunology, you still just went for a half day. And that half day was set. And then you had to do PCC up to 3 months. I think it was 3 months sometimes in a year. So you would go to medicine clinic and you would see whatever walked in the door, and you'd see them all day, and then you'd go home at usually around 6. It was always later than 5. And this was extremely unpopular for reasons y'all can imagine. It would be like it was not very popular. So we did away with that. And I do like our current system, a lot more than that. And I think that any of the residents that did both would definitely say our current system is much better. So anyway, this is what, from the 2007 poll, the residents thought would be the best method and that the program directors thought. So we have these 12 programs that said, we're going to fix this. We're going to solve all these problems. We're going to separate inpatient versus outpatient, since this is what everybody has decided to say is important and that this is the worst part about the outpatient experience. And we're going to do this. So there were 3 different things that were actually started and proposed. The most common, 10 of the programs did the X+Y, which again we're going to focus on. And that is where you have 3 to 6, some of y'all know this better than me because y'all made these schedules, but you have 3 to 6 weeks of inpatient or subspecialty rotations, and then in between those you have 1 to 2 weeks of ambulatory time. And so that was the most popular that a lot of the programs did, and again that was 10 programs. There was University of Cincinnati did the ambulatory long block, which I thought was an interesting idea. They, between month 17 and 28, so somewhere between your 2 and 3 year, they did 10 months of burst continuity. So you had your elective months kind of clustered together, and you would have many more continuity clinics during those elective months. And so they did that. And then one program, Mayo, did this 50-50 inpatient outpatient where they rotated. Month 1 you're on wards, month 2 you're on elective, wards elective, ICU elective, and they just rotated it to see, and then you didn't have continuity when you're on inpatient, and you had more continuity when you were on outpatient. And they looked at that data. So again, just to go over the X+Y, and some of y'all know this already, but just for those who aren't familiar, this is our traditional clinic setup where you have half day per week, no matter what you're on, except for ICU usually. And then the X+Y, this is a 4+1. You have 4 weeks of inpatient rotation where you do not have any continuity, no clinic exposure, and then that last week you have clinic week. Now, you ask, do you just go to continuity all day? So most programs don't have you go to your continuity clinic every day, all day on the clinic week. Most programs have some time for didactics, some protected time for research during these clinic weeks. Some send you to subspecialty outpatient clinics. So you might go to HEMONC clinic, and you might go to pulmonary clinic, and you might go kind of get shopped around to different outpatient clinics, as well as seeing continuity patients. So again, the general idea is that you have, if you are 4+1 like this is here, you would have 5 different groups of residents, and they would all rotate, and they would all be kind of staggered so that you had one group in the clinic at all times. And as you can see, this is not necessarily the most simple of, and I know our chiefs this year know, and last year know, it's not the most simple scheduling system. And Kelley had the generosity to bring the sample schedule that they came up with, and y'all can come take a look at it if y'all didn't see it at all, but it is pretty complex. So, why theoretically would this system be better than our current system? So some different organizations have established we have problems with our current system with these conflicting inpatient and outpatient rotations. So theoretically, it would be better because you would have focused time inpatient, and then you would be able to focus when you were outpatient. You wouldn't be getting constant calls, and you wouldn't be worried about, oh, I'm on call today, I have to be back by 4, or oh, I have 3 daytime admits, I need to get back over there. Let me see through these patients so I can get back to my, my ward team. You would not, so if you were on a 4+1 system, you would not be away from continuity clinic longer than 4 weeks at a time. So even though you would have your 4-week block where you were not having to go to the clinic, you would still be in there every 4 weeks or every X weeks. Most programs are doing 4+1. And then the other thing that they theoretically like about this is that there's an increased sense of team, because you have to rely on your teammates if you need a continuity clinic patient to have anything done in that interim between the time you're in clinic. So this is theoretically why it would be better. So we talked about the 10 programs that went to it with the task force and trying to come up with a better way. A lot of different programs have adopted this model for their internal medicine residency, and we're going to talk about some of them later. So your continuity clinic, what happens is, since you're only there every 4 weeks or so, your cohort, your group of residents is divided into sub-cohorts, and you're paired with a specific attending preceptor. So this is really one of the only ways that it makes it fluid and makes it work. So say Adam is out, and we need to follow up on a creatinine in 2 weeks. And so he's not going to be there. He doesn't want to hassle with it. He's going to be on wards. So he would be paired with Attica, who would be paired with me, who would follow up on it. And we would have continuity through our team approach. That's how it works in theory. And so all the follow-up and the lab results, if it's not in your little scheduled 4-week time, would be handled by your team. So where does this time come? A lot of reasons it's popular is because of this increased clinic time, and so it's easier to meet the 1/3 requirement by the ACGME. For example, North Shore, this was striking to me, they went from 90 half days to 150 for their PGY1s and 180 to 300 for their PGY2 and 3s. So a big increase. So where does it come from? Are you doing less ICU? Are you doing less wards? I mean, not less night float. I'm sure everybody would love it if we're doing less night float. But no, usually what happens is they decrease your elective time, but it's somewhat, it's usually interspersed into your ambulatory week. So yes, you might have less time on your endocrinology rotation, but you're going to go to endocrine clinic while you're on your clinic week. Does that make sense to everybody? Yeah. So now I was going to talk about the numbers that we have found. They've done lots of studies on this to see. The problem with these studies, as y'all can all imagine universally, is these are surveys. So surveys, we know, are not the strongest studies. It's hard to actually prove a lot of things with saying, hey, are you somewhat satisfied or less somewhat? How much do you strongly agree, less strongly agree, strongly disagree? We love these, right? So all of these are based on surveys. So we'll start with Lehigh Valley, which this was one of the first residency programs to go to the 4+1. They went in 2008 to the 4+1. They are a smaller program than ours. They had 48 and 49 residents respectively. And they did surveys paired with focus groups. So they didn't just say, hey, are you satisfied? They also got together and talked about it. The response rate was in the 60s. One thing with this is they only had 6 and 8 faculty members, so not a lot of faculty were involved in their surveys and their focus groups. But they looked at what the surveys were saying and compared them to the before and after means. And what did they find? So we will look, this is the resident survey results. So these are residents, and 1 is strongly disagree and 5 is strongly agree. So again, these are kind of inherently flawed surveys to start with. But the residents said they felt that their ambulatory experience at clinic was a better reflection of outpatient general internal medicine. They felt that that general internal medicine might be an enjoyable field of medicine. They thought, so to start with, they said, I feel that a 1/2 day clinic per week is an ideal ambulatory training model. So before the 4+1, that was 2.8. And again, remember, 5 is strongly agree. So to start with, they were more pro-traditional continuity clinic. And then after the schedule, they said, you know what, we don't think that's the best schedule anymore. So they kind of changed their mind a little bit. Again, we'll talk about a little bit of bias that could have been introduced easily through this, but anyway.
Just using the word ideal introduces gigantic.
Right. Well, and what I love is we're saying, hey, residents, you know what we're going to do? We're going to change your schedule so that you like it more and you have less conflict. And then we're going to send you a survey and ask if you liked it more and had less conflict. So we're kind of setting you up, and these questions, as you pointed out, we're they can be a little bit leading at sometimes. So anyway, yeah, this is absolutely, I 100% agree. These are very interesting question. So, but they did, we'll continue to talk about them. So this is Lehigh Valley. So they did feel the pace and session scheduling at the clinic was adequate, and that was better after the switch. They felt that patients had good access to care, and that was better, and they felt like they were able to focus more on their outpatient education while in clinic, and that was better. So again, this was, and then the faculty, I almost didn't put this slide in here because it was only 6 and 8 people, and not many people. So how did the faculty feel? They felt that the ambulatory experience provided adequate opportunity to prepare for outpatient experience, and that they more strongly agreed after the 4+1. And then they felt that this clinic was an ideal training environment for the residents in outpatient medicine, and they more strongly agreed. And they even worded that question differently than they did for the residents, which was interesting. They did not see a difference in their residents' ability to focus while on outpatient education, while in clinic. So what did they find in their focus groups? And of course, if the survey was flawed, let's talk about personal people opinions. So these again are just the residents, what they reported, and the faculty, what they reported. So the residents did report a decreased conflicts between duty and a better learning environment in the 4+1 system. They said that they felt like their sense of team increased dramatically, and they felt that there was better continuity, which, before you look at it, and if you were to just say, hey, do you think that having a half-day clinic every week, you would be able to provide better continuity versus you're only there once a month? And just intuitively, it makes sense that the continuity once a week would be easier to have continuity. But we'll talk about that again a little bit later too. There are more studies involving continuity. What did the faculty report? Again, this is 6 and then 8 faculty before and after. They thought that the care was improved. They thought the residents were more engaged, that they might have had more increased ownership of their patients, and yeah, maybe the residents seemed less stressed out. So we talked about some of these already. This small number of residents, and it's a relatively, it's a program half our size, so it's not apples and apples. There was no tracking mechanism for paired comparisons, so this was just, you have this 44 residents and then you have 46. They didn't track who said what. You don't have a control group, obviously everybody switched, so to the 4+1. And again, it's a single program with one clinic site. They used a non-validated survey, which the next study used a validated survey. I'm not sure, it's still a survey, I'm not sure how helpful that was. And then I already spoke about the responder bias. When we tell you beforehand that we're doing this for a certain reason, then we ask you if it happened, there's probably some bias introduced into that. So anyway, the next study on an individual program I found was through North Shore. This is a little bit larger program, 82 residents. They had experienced both the traditional and the 4+1. They had 3 training sites, and they looked at different primary and secondary outcomes, including satisfaction, if they had a good experience, if they had good learning opportunities, and if they felt like they had as much continuity. So they paired this with a small group too. So they did the survey plus the this nominal group technique focus groups, and they ended up aligning those to make sure that they matched. So they looked at 38 different items, including learning opportunities, quality of faculty, fragmentation in your care, and then satisfaction with your ambulatory experience. And this was, again, a little bit higher number, 78 residents responded to this survey. And then 20 of those residents were randomly selected to go through the small groups. What did they find? So, I have to talk about all these. I thought I had boxes. So they found that overall they felt that the care was less fragmented with fewer interruptions. They felt that they were more satisfied with their ambulatory training in general, and that they were more confident in their abilities. So they had a positive survey response too. And then moving on to Mayo Clinic's 50-50 model, and this is what I talked about earlier. This was similar to what we had before when we had half-day plus PCC. What did they find? They had, traditionally they just had, the only difference in Mayo is that they did not go to clinic at all when they were on inpatient service. So they looked at the panel size and saw that their panel size increased when they made this change. Their missed appointments decreased, their continuity decreased. So this was a big negative. And then they said that their perceived outpatient safety and teamwork improved from the resident standpoint. And then the educational outcomes that they looked at, your attendance at teaching conferences improved. And that makes sense if you're not trying to, oh, I have to go to clinic and then I have to go see my 3 admits. You might be more prone to go to conference, but kind of feel like the people that go to conference make it a priority anyway. But anyway, and then the attendings thought that maybe the resident clinic performance improved. So what did they not see a change in? Again, this is Mayo Clinic's 50-50 model. They did not see any difference in chronic disease management, preventative care, or patient or resident satisfaction. So residents weren't more happy, patients weren't more happy, and it didn't look like we did a better job managing our patients. This is the study that was the most interesting to me. So Texas Tech, and this is what Dr. Greenberg and I were talking about. I think this is the study you were talking about earlier. Texas Tech decided to take these 12 programs and do a cross-sectional study. So they ended up serving 713 residents and faculty on a scale of 1 to 5. This switches it. 5 is very dissatisfied. So 1 is very satisfied, 5 is very dissatisfied. And then 75% of the residents responded, and they did so after their 9th block of ambulatory medicine. So they had a good chunk of this new system to see how they liked it. They divided the programs into the 3 different programs, and they found that there wasn't a huge difference in the learning environment, working environment, clinical environment, personal experience. So really the 2 differences they found is that the satisfaction with the faculty preceptors, again, 5 is very dissatisfied and 1 is very satisfied. So they were less satisfied with their faculty in the traditional model, and they were more satisfied in the combined block and traditional and in the block. So seemed to be happier with their faculty in the block system. But again, I wanted to point out that their personal experience, and they rated it no differently across the board. Physical environment, I almost didn't put that either. That was worse on the combination, but I have no idea why that would be, and neither did the study. They did find another difference in the perceived continuous healing relationship of the residents, so in the combination model, and again, this would be similar to our old system where we had continuity plus ambulatory blocks dispersed. They felt like they had more of a continuous healing relationship with their patients. So this is what we would expect to find when they talked about the conflicting duties between the inpatient and outpatient. They did see that the block had less conflicting duties, and that was across the specific, and then generally when they asked them, hey, did you feel like you were pulled in 2 different directions? Of course, the people who weren't in 2 different places at the same time said, no, we didn't feel that way. So the block outperformed there when we were talking about the conflicting duties. So conclusions of the study, the resident satisfaction was actually similar across the groups. So that was a surprise to me because all of these individual studies of these individual programs had said our residents were way more satisfied with the block schedule. But with the cross-sectional, they said they were pretty much the same. The only difference was that the satisfaction with the faculty was lower with the traditional model. I think that this might be in part to, like we talked about, when you do the X plus Y, the block model, you have to pair your faculty with your residents so that you have continuity at some level. So when most of these programs moved to the 4+1, like Dr. Moorhead would be assigned ISAMI, and he's his preceptor. And so you had more continuity with the faculty. And so they thought, and I agree with them, that that was probably what contributed to the increase in the satisfaction of the preceptors. And then they found that the continuity was not independently associated with resident satisfaction. So that's different than the study we had seen before that said that residents are much more happy if they see the same patients. Block schedule did minimize perceived conflicts. So it's kind of what we would expect. If you're not supposed to be covering the wards and the clinic at the same time, you're going to feel like you have less conflicts. Limitations, this was only 12 programs like we talked before. The response rates did vary among programs. There were some programs that had excellent response rates and others that had pretty bad ones, and so we don't know if maybe the ones are like that had more negative feedback on the block schedules. We're just so disgruntled and I'm tired of this and I don't even want to talk about it anymore. We don't know. And then of course there's no randomization, and like we talked about the survey format, these questions, as you can see, are there. It's hard to design a survey study. I'm not judging them. I'm sure they did the best they possibly could, but it's hard to come up with questions and get honest answers. So when we look at, so we talked about what our residents think. What do our patients think about these new systems? So the same group, Texas Tech, did another cross-sectional study, and they sent 17 surveys out to, or 17 patient surveys per each resident on this consumer assessment of healthcare provider system, which is a validated satisfaction survey for patients. And what did they find? So the traditional and the block were actually similar, but were better than the combination. I can't remember if yeah. So they asked questions like, how often did your doctor explain things in a way that was easy to understand? How often did your doctor listen carefully to you? So again, no big difference between the traditional and the block. Again, the only thing that was different was that the combination did worse. And what we saw when we had PCC is that when I did my clinic month and they weren't my patients and I wasn't going to see them next time, you are much less likely to, you don't develop that relationship with your patient. So unless you were just extremely awesome and you just are a wonderful resident, a wonderful person, you may not take the extra time with that patient because I'm never see this guy again, you know. So I don't really want to explain to you why your creatinine may be 1.4. Back then we had a problem with people getting labs because nobody wanted to actually follow up the lab. And so we'd say, get it before you come to the next clinic appointment. And then it would be 4 years and patients with CKD and on all sorts of medicines would not have labs. So this makes sense to me. Patients felt like they had less connection with the residents in the combination as opposed to the traditional and the block. But again, the traditional and the block did the same. The patients were equally satisfied. Again, how often do your doctors show respect for what you had to say? How often did the doctor spend enough time with you? So we talked about this, importance of continuity, and this is my big thing right now. I'm just trying to get y'all's continuity better in the clinics. And we'll get there. But you have greater patient satisfaction, you have greater provider satisfaction, your staff are more satisfied. You have decreased use of resources. We have reduction in use of the ER. My patients I misunderstood something Dr. Bass told me, so all my patients had my pager number. And so they paged me directly when they were running out of their Lasix. And that might be the ideal system. I don't know, but it is difficult to maintain and sustain when you have a lot of patients. But anyway, when they have a doctor that they can get in touch with and get help from, they're not going to show up with their meds out for 2 months. So, and then we have decreased hospitalizations. I am running out of time. I will quickly go through. So what about the continuity? I'll just tell you the main points. They looked at continuity. This is the same group, Texas Tech. They looked at continuity from the percentage of, or from the vantage point of the patient. So how often did the patient see the same provider, which is UPC, and then they looked at it from the vantage point of the physician. How many patients are you seeing, or patients that you've seen before? So when we did the block schedule, the UPC, which is again the vantage point of the patient, they had better continuity with block, which was a surprise for me, as opposed to the physician. So the physicians would have worse continuity. And what probably caused that is that you're seeing more patients, your panel is usually increasing, and so you're getting an influx of new patients. That's how I justified it, and the Texas Tech people justified it. So again, the patients have better continuity, but the physicians have less continuity. And that's what we just talked about. So drawbacks, it's based on, this could be a positive or a negative. In my mind, it's a negative, but in other people's mind, it's probably a positive. So it's based on this team model. So you might not be the person that's taking care of that lab value. You have to trust your colleagues, you have to trust your attendings. You need a consistent attending provider, which can be tricky to schedule it that way. If you need to see a patient back, again, you have to, before your 4 weeks, you have to rely on this team to take care of your patients. It is very complex, as our chiefs from last year and this year know. It's not the easiest schedule to put together. And also you want to think about your people that rotate in and out, like anesthesia and fam med. it is, and med peds, it works, and they did it, y'all did it successfully, but it is tricky. And then of course you're not in continuity for however many X weeks is. You have different start and stop dates for your rotations. And then one big problem that a lot of residents have issues with is that now we have a lot of say in when our rotations are and when our vacations are. We can put in requests, and for the most part the chiefs are super wonderful and nice about trying to accommodate everything. When you are in these block schedules, you have your schedule a year in advance, and if you need to change it, it is way too complicated to change from a chief standpoint. You find somebody to switch, and that's what all these programs have done, is that you have to find somebody to switch on your own. So all the other variables I'm not talking about. So institutional culture, I can't tell you how this would go over here. I don't know. Our culture is going to be different than Johns Hopkins. It's going to be different than Mayo. Our no-show rates, training priorities, ancillary staff, resident factors, these are all things that we can't, again, it's not necessarily apples and apples. So in conclusion, when these programs do implement the X plus Y schedule, they do minimize the inpatient versus outpatient conflict. I think some people that have been doing this a while would probably say, is this really a problem? And then it's reported as a problem, but we don't know if this is this the thing that most needs our attention with our education? And I think that's a very good question. I don't know I don't know what the answer to that is. This is not easy to initiate. A lot of times it's because residents don't want to do it initially. They did seem less stressed and less interrupted, but overall the last cross-sectional study said they weren't any more satisfied. So it's just it's a difficult thing, and of course I can end it with, we need more information. And we'll never know because every program's different, so we would never know how it would go over here. So what kind of questions do y'all have?
I'll make a plug for ambulatory care. I'm a part of a research team that's doing focus groups, has done 40 focus groups with patients who've been hospitalized in the last 3 months. Mm-hmm. Here is a theme, whether it's Boston or Tesh Action Community Clinic in Franklin, Louisiana. They love their primary care doc. They trusted their primary care doc. They felt their primary care doctors knew them and knew their health history. Mm-hmm. On the other hand, the hospitalists, they say, I see a different doctor every time in the hospital. I don't think they know me well enough or know my history well enough. Mm-hmm. So that was just a patient point of view that's a real plug for ambulatory generalist clinic based care.
Yes, sir.
Not to debate that, but that's not a residency thing. That's a healthcare in the United States doesn't change in the last 20 years to where there are now outpatient doctors and hospitalists, and that has nothing to do at base with residency. The residencies have evolved to fill the needs of the medical system. Now, I agree, having been for 10 years a primary care doctor who took care of patients in the office and in the hospital, that is the ideal system for continuity, for knowing the patient. And I thought it was a great system, but I believe the third-party payers, the hospitals, were the big motivators to change to a two-tier hospital versus outpatient system. That changed, the HMOs who were big when this all started, of what changed the delivery system entirely. And we can discuss this later for hours, but I think residencies are just trying to respond and don't necessarily do a great job of meeting the needs, but that's all we're trying to do is to fill the holes that the system has asked us to fill.
Well, you can't
I don't support the change that's occurred, but the system be masquerade.
Well, first of all, thank you so much for doing this. I know it's been a strain for you to be the clinic director. A lot of the studies talked about resident satisfaction, so I had to say two things. One, my first day of work here, I was so young, was the PCC clinic, and the only way to describe the mood of the residents in the room is hostile.
It was not a low for a patient.
So now the residents come to me, the chiefs come to me and say the residents are unhappy, and I'm like, unhappy is an improvement. I'll say unhappy.
So it was so funny to me how some of these programs are going to that system. I was like, ooh, don't do that. Like, what are you doing? Step back. Don't do that.
Does that also decrease continuity for
It does, right.
But here's the sad part. When we switched, we did a study with our patients, which of course we didn't publish, because some of the residents had their continuity clinic. You always had continuity and you had PCC.
Right.
Well, we picked up on patients that had already seen their supposedly continuity physician, and we pulled patients from the PCC clinic and the continuity clinic and asked them if they had a usual provider. And there was no difference. As far as our patients were concerned, they didn't even know that they had been seen in, what do you mean PCC? Or, no, I don't have the same doctor. I got a different one each time. So we failed either way.
And we're still struggling. Everybody on my inpatient team who's followed a medicine clinic, every single one this month, who's your primary care doctor? I don't know, I go to medicine clinic. That is not the response I want. I want you to know their name, and I want you to know, so.
But on the other hand, if you say that the block system fosters a team care approach, and that's what the HMO system was. And you're not a doctor's patient, you're the HMO's patient, and they will find a doctor to see you, within a day if you're wanting a doctor, because we're all interchangeable with that. And that's sort of how the U.S. medical system has evolved, grudgingly, because they still say, I wish for the days when I had my doctor, but no, I don't want to wait 4 days for the appointment for my doctor. So I don't know how this is going to solve it.
Yeah, I think that we could just say if this is a conflict, inpatient versus outpatient is the big problem and the big priority, then this might be our answer. If that's not the big priority, then it's maybe not our answer.
Just a matter of resources, here it does solve another problem. Is right now the residents they complain about speed and efficiency. If we did do something like that, it would be easier for me to give every resident 2 rooms or 3 rooms, and you know that because of our room to doctor ratio.
Right.
So it does certainly appear to solve on the surface more problems than it seems to generate.
After these studies, I should have not have been surprised that having fewer patients scheduled was very much increased resident satisfaction in the clinic, which, I mean, if you're having to see 8.5 days, I mean, y'all know that's a lot different clinic than I have 5 patients show up and I'm going to take my time to see all of them and be thorough. You feel much more satisfied after that 5-patient clinic